This patient is a 68-year-old male who presents to us for second opinion for evaluation of squamous cell carcinoma, early stage microinvasion squamous cell carcinoma of left mandibular gingiva. This gentleman had a history of smoking in the past and occasional drinking, but he had stopped many years ago. He was seen at another institution, and they were offering him a much radical resection of the entire half of the jaw and free flap reconstruction and neck dissection, tracheostomy, and the whole 9 yards. When he came to see me, examined him, he does have a history of mucosal disease throughout his oral cavity. Back in 2014, he had carcinoma in situ, his lower mandibular buccal vestibule, and that was excised by another surgeon with negative margin. It was CIS. He had 2 dental implant placed about 10 years ago by his local periodontist, and most recently he was seen by him, and he noted that one of the implant has loosened and there was some granulation tissue around the implant. So he was smart enough to send that tissue in, and the other implant, he had 2 implants placed. The other implant was loose, so he removed that and he put some bone graft material in the socket. The soft tissue was around the implant that was more anterior, and that tissue came back as squamous cell carcinoma with microinvasion. So here we have a gentleman who has apparently pan-mucosal disease, and it was caught at the earliest stage. The one important thing about oral cancer, hopefully, luckily, it's not as common as breast, colon, prostate, or lung cancer, but it's a number 6 cause of oral cancer in the United States. In other countries, like in India and Southeast Asia, it accounts for up to 40 or 50% of entire malignancies. Back to this case, this gentleman had his workup done with the PET scan, CT scan, and I presented him at a tumor board, and we basically gave him a more appropriate treatment with marginal mandibular resection, neck dissection, and preserving his mandible. And if the distance of the tumor away from the inferior border is adequate, sometimes we don't need to put a reconstructive plate across if the bone is strong enough. But we did give him the option of that if the bone is thin enough, we will put a reconstructive bar across it. And he was taken to the operating room, and all the frozen sections were negative. The bone margin was negative. It was all superficial. It was squamous cell carcinoma with microinvasion, and all the lymph nodes in his neck were negative. So the outcome was excellent for him, and he didn't need a radical resection of his half of his jaw. So the concept of oral cancer has 4 pillars. One is prevention. Remember, this is the cancer that could be prevented. Majority of the time, we're talking about smoking, alcohol, autoimmune disease, history of radiation, obviously UV light, and human papillomavirus. So, there is a preventive disease for the most part. There's some genetic component to it as well, but majority of them are risk factors that could contribute to oral cancer. The second phase will be early detection. That's what's important to communicate with our general dental practitioner and our general medical practitioner. Earliest stage detection is the entire thing about oral cancer. If you catch them early, they'll have a much better outcome, and it's a curable disease. The third thing is referring it to a center that they have multidisciplinary approach. I present my cases at our tumor board, which is on every week, and we have a huge number of people with different specialty and subspecialty in treating cancer. And we put all our cases in there, and we discuss it, and we get the best treatment outcome for our patient. Last thing is follow-up. Remember, cancer, you cut it out, there's potential for it to come back, but there's a risk factor that you continue to use tobacco or alcohol or genetic or some other additional risk factor that could contribute to development of cancer. So it's very important to follow these patients long term. We see them frequently within the first 3 years, and then we keep them on the radar. And had this patient been missed, and if that tissue was not submitted, this cancer would have gone deep into the jawbone and will need a major resection to convert that to a stage 4 disease, and the survival rate will be much lower. So again, early detection, prevention, appropriate referral, and close follow-up are the 4 most important things regarding cancer in the oral cavity and in the head and neck region.